Ochoa, and I'm the Chief Operating Officer at Landmark Ventures. We host the Social Innovation Summit, where we convene corporate responsibility executives, foundation leaders, and innovators to share groundbreaking initiatives and develop partnerships. As part of the Social Innovation Summit's annual events, we are honored to partner with organizations to amplify conversations and solutions around our biggest issues facing the world today. This summer, AARP is teaming up with the Social Innovation Summit on a 7-part series to talk with national leaders about issues that impact longer and healthier lives for all communities. We have all seen that the COVID-19 pandemic has further exposed inequalities that have long existed. And critically in this moment, we are seeing these issues rise to the surface. Although disheartening and absolutely frustrating, it gives us the opportunity to seize this moment to rebuild our communities, to serve everyone equally, to help us ensure everyone is able to live longer and healthier lives. And that's what this series is all about. Our inaugural event featured Wes Moore, CEO of Robin Hood Foundation, and today we are equally excited to bring together a group of important thought leaders to discuss longevity, building a more equitable future. Our featured speakers today include Dr. Helene D. Gayle, President and CEO of the Chicago Community Trust, Dr. Patrice A. Harris, immediate past President of the American Medical Association, and Dr. Keith E. Whitfield, Provost and Senior Vice President, Academic Affairs of Wayne State University. We are also pleased to be joined by AARP's Dr. Debra Whitman, Executive Vice President and Chief Public Policy Officer, and Dr. Erwin Tan, Director, Thought Leadership, Health. As you can tell, I'm the only person on this event that is not a doctor, so my mother will be very proud today. We've sent all attendees a digital brochure with the detailed agenda for today and our speaker bios, and we are taking questions from the audience that will be asked in each fireside chat conversation. So please submit those questions through Zoom throughout the event. So without further ado, to get our program started, I am pleased to welcome Dr. Debra Whitman.
Thank you, Mel, and thank you for the partnership with the Social Innovation Summit. Today's conversation comes as a difficult time as we wrestle with the tragic impact of the coronavirus pandemic and simultaneously are witnessing a profound, historic assessment of racial injustice. The coronavirus pandemic is highlighting inequities that we have long existed in our society. We know that communities of color are being hit disproportionately hard by COVID-19, both in terms of their health and the economic impact of the recession. In terms of health, we've seen in Chicago where African Americans are 30% of the population, yet they comprise 70% of those killed by the coronavirus. In Virginia, nearly half of all coronavirus cases are in Hispanic and Latino communities, but they only make up 10% of the state's population. Unfortunately, this is not a new story. The life expectancy gaps between white Americans and people of colors exist due to a range of socioeconomic factors such as income inequality, access to health insurance, and access to quality health care. Let me give you just one example of the work. Let me just give one example of the critical work that we had before us. In New York City, residents of East Harlem live about 71 years, while those living just a few blocks away in the Upper East Side have a life expectancy that's 2 decades longer of almost 90 years. In the city of Chicago, differences by neighborhood are up to 31 years. Imagine having 31 more years with your family, with your friends, to give back to your community. These are the lives that are lost. The public outcry across the nation over racial injustice following the death of George Floyd require us to think about these numbers in a different way. Far too many African Americans are dying far too young in this country. Now, we know the disproportionate impacts of health and longevity on people of color are not random, but are instead the result of inequality due to a lack of social, economic, and political opportunities. And more importantly, we know as a society, we need to do better. So today, AARP is on the ground making social change in all 50 states and the US territories, as well as here in DC. I'd like to give a special shout out to my colleagues in our Illinois state office, led by Bob Gallo and Mary Anderson. AARP Illinois is an active member of Chicago Mayor Lori Lightfoot's Racial Equity COVID-19 Rapid Response Team. And the AARP Illinois staff has also created a 3-year racial equity plan for the state focused on advocacy, community engagement, and volunteers. And they're leading the collaboration of organizations to conduct a disrupt disparities research on Illinois with a focus on Chicago and Cook County to identify racial disparities among older adults in health, economic security, and community. The work that our colleagues are doing in Illinois is an example of the work that AARP is leading across the country to empower all people to choose how they live as they age. Now, one of the best parts of my job is working with my star-studded thought leadership team who helped plan today's session. And Mel mentioned the collaboration of the 7-part series between AARP Thought Leadership and the Social Innovation Summit. We're working to cultivate new ideas, inspire bold solutions, and connect with thought leaders like you. I'd like to give a special shout out to Stacey Alexander for pulling together this session and to Erwin, who will be today's moderator. I hope today's amazing speakers will show us how to construct a system so that all people can live a long and healthy life, regardless of their age, race, or income. Back to you, Mel.
Thank you, Debra. Now for our opening discussion of the day, we are excited to welcome 2 leaders who have been working on this for years and who are really 2 of our nation's foremost thought leaders in this area. Dr. Patrice Harris of the American Medical Association and Dr. Helene Gayle of the Chicago Community Trust. Helene, I'm sorry, I apologize. To moderate this fireside chat, we are pleased to welcome the Director of Health on AARP's Thought Leadership Team, Dr. Erwin Tan. Welcome, everybody.
Hi, this is Erwin Tan. Thank you very much for joining us, Dr. Harris and Dr. Gayle. I would actually like to start this conversation. Dr. Harris, if you could quickly introduce yourself and answer this first question. There are obviously great disparities in how different communities are experiencing the coronavirus pandemic. African-American nation is dying at a much higher rate. What do you think is driving that difference, and what can we do to ameliorate the disproportionate impact of COVID-19 on communities of color?
Well, again, good afternoon, and thank you so much for having this conversation. And by the way, I think the title is so telling because it really highlights 2 key aspects, really, that you just heard about, and that is longevity and equity. And first of all, I will say that if we are not having a conversation about health inequities in any conversation about health, then that conversation is incomplete. And so that's the first thing. We want to make sure that every conversation around health has some thought or discussion around equity, or else it will be incomplete. And I think we know the drivers. We know there is inequitable access to health care. Not everyone has access to affordable, meaningful health insurance. We know that people without health insurance live sicker and die younger. What about access to affordable housing and transportation and living in food deserts? And so these are all the issues that we talk about as the social determinants of health. I like to speak to them more broadly as just determinants of health, but we need to go back, maybe go up further upstream and look at some of the causes of some of these different determinants of health, and many of those are structural. Housing policies, discriminatory housing policies from years ago. We have to talk about, and our country is talking about it now, racism, structural racism, as well as interpersonal racism and implicit bias. So these are all the drivers of where we are today. But the key, I think, now is what are we going to do about it? What action do we need to take? I'll just say, and I know we'll have a chance to elaborate further, but the American Medical Association established a Center for Health Equity about a year ago. We hired our first Chief Health Equity Officer. So we wanted to make sure we are demonstrating our commitment to leading on this issue and partnering on this issue. We have a partnership in Chicago I'll talk about a little later. And one final point I will make in this introduction is that it's not this problem or these problems are not the health systems alone to solve. And so we need the business community in and engage city planners and developers who are deciding housing and complete streets and whether or not there are walkable, well-lit sidewalks. So we need an all-in approach to this. And certainly the issue around health inequalities are just not the health systems and the usual suspects of health system reform. We need everyone engaged on this.
Dr. Harris, thank you so much. I want to turn to Dr. Gayle and to have you introduce yourself and your leadership in Chicago and give us an idea of what's happening in Chicago today. We would greatly appreciate your insights based on your work and recent experiences on what's taking place in terms of the health of the residents of one of America's largest cities.
Yeah, thank you so much. And it's great to be with you, Dr. Harris. You've done a great job over the last few months being a real spokesperson for these issues. You know, and I would just say I head the Chicago Community Trust, which is Chicago's community foundation. And our focus is really to make sure that we stand with the community, working to address the most pressing challenges and the things that stand in the way of people here in this region being able to realize their full potential. And when I came here about 3 years ago, we stepped back for a little bit and tried to think about how could we use our resources to make the biggest difference. Now I'm a physician, and so obviously, I care a lot about health, but when we looked at the challenges that were impacting the community here, we recognized that if we didn't get to the root causes and address some of the kinds of issues that Dr. Harris talked about, the social determinants or determinants of health, we weren't going to be able to have a real impact. So what we said we wanted to focus on was closing the racial and ethnic wealth gap and working with communities to really look at what are the obstacles that stand in the way for all people being able to realize their economic potential, which is such a huge driver for health, education, violence, a lot of the issues that plague our city, our region. You mentioned in the introduction, they mentioned the life gap. Chicago has the largest life expectancy gap. If you live downtown in our beautiful downtown, you can live to 90 years of age. But if you go 9 miles away to Black neighborhoods, your life expectancy plummets to 60 years. Unacceptable. It is unacceptable that today in America, we allow people to have a 30-year life expectancy gap. But we know that's about access to jobs, access to safety, safe neighborhoods, nutritious foods, clean air, safe water, all of these other things. So, again, as Dr. Harris said, if we don't think about these broader issues, we will not be able to address the challenges of health disparity. And we're seeing that played out in I guess even doubly amplified as we look at what's happened with the coronavirus pandemic and how it's affecting Black and brown communities disproportionately, both in terms of new cases as well as deaths. So that's some of how we're trying to think about it here in Chicago.
Dr. Harris, we've heard these disparities in Chicago, especially in the disparities in life expectancy. Did you want to follow up on the drivers that create these disparities and this chasm in life expectancy?
Yes, and let me also say what an honor it is to be with Dr. Gayle. I've been a fan of hers for so many years. I know she was in Atlanta for a while, which is where I have lived since coming to train at Emory. And also want to note that I'm a psychiatrist, and we may be able to talk a little bit later about the mental health issues, because COVID-19 really has brought into stark reality a couple of what I call pre-existing conditions in this country, right? Many, but two I will highlight. Of course, we've already highlighted and talked some about the health disparities and the fact that, African Americans originally, especially in cities like Chicago. Unfortunately, they had this data early on. Not everyone was collecting this data, but the AMA has asked for this data. Others have too, and now we have data to demonstrate that though African Americans may make up a certain percentage of an entire state or region or county, they make up a far greater percentage of those who are hospitalized or who are dying. And so all of the drivers that we spoke about are contributing to that. The other issue that COVID-19 has brought into stark reality is mental health. The need for mental health, the importance of mental health as a significant part of overall health care, but also, and unfortunately, just like health inequities, pre-existing, underfunded, under-resourced mental health system. And so those are two huge drivers. And we know there again, we've seen over the last decade an increase in the number of suicide attempts. Fortunately, overall, but also particularly among our Black and Latinx youth. And along with that, unfortunately, we have disproportionate, inadequate access to care for mental health services. So all of these are those drivers. And what we really need to do, again, is to have everyone in the room as partners on this. You know, I think I talk to the business community a lot here in Atlanta, but across the country. And when businesses decide to locate or relocate to an area, they look at the health of potential workers, and that includes their educational attainment, opportunity for education. And so this is why this matters, right? Not to individuals and not just to those who are stakeholders in healthcare, but really everyone. And so we really have to make sure we are making those or taking action, not just talking about it and knowing about it and taking action. And certainly I'll just say in Chicago, the AMA is headquartered in Chicago, and we have a partnership with the west side of Chicago, hearing the data that Dr. Gayle just mentioned. And we decided that we certainly are a national organization, but we could pilot programs and partnerships that then could be brought to scale in the larger community. So we are participating in a pilot program right in the west side of Chicago. And Dr. Gayle also mentioned an important point that needs to be amplified. We have to go to the community and work with the community, not go into a community and tell a community what they need, but we need to ask those questions. We have to earn trust. Particularly in the African American community. That is another driver, an important component of how we get to change. For many reasons, I think folks know about Tuskegee, but many reasons there is a mistrust and a distrust of the health system, really a lot of institutions. And so we have to go in, work with the community, listen to them, meet their needs. And we are doing that at the AMA in addition to our larger, of course, national portfolio, but right there in Chicago to be a model for those institutions who have resources on something that they can do. And again, it's not a one size fits all. Each area might do something else. I'll just mention one last thing, not related to my work at the AMA, but I've been a part of a group in Atlanta called ARCHI, the Atlanta Regional Collaborative for Health Improvement. And here we are trying to bring all of these stakeholders together to improve the health of the Metro Atlanta region. And we had a series just last year on racism and how that has driven redlining, those discriminatory housing policies. And if you look, at least here in the Atlanta area, and I'm sure this works in other areas, at the redlining policies where African Americans could not get mortgages in certain areas decades ago, that tracks with those zip codes that Dr. Gayle was talking about today. So again, it really requires attention to all of those issues. We need to make sure that hospitals and health institutions in under-resourced areas have the resources that they need. The schools have the resources that they need. And it's not about giving someone more than what someone else gets. It's about giving someone what they need to have an equitable opportunity for optimal health.
Dr. Harris, thank you. And I just want to pause to say that for the audience, please submit questions. This is a great conversation between important thought leaders. Dr. Gayle, I want to turn back to you, talking about what Dr. Harris called determinants of health, and racism being an important one of them. In terms of What steps is the Chicago Community Trust taking to address some of these core issues, these determinants of health? And if you want also to talk about the mental health issues, which are only being magnified by the COVID-19 crisis.
Yeah, so I'll step back a little bit, and I would just like to follow up on a couple of comments that Dr. Harris made. One, I think, we put a lot of focus on the health system, and we should, because, we're a country that ought to be able to provide access to health services and access to quality health services for all people. So we've got work to do in that regard. And we know that our health systems have not built the kind of trust that is necessary for particularly for people of color, and very specifically for African Americans, because of the legacy of things like the Tuskegee experiment, but also things that people experience today, where we know that Black patients don't necessarily get prescribed what they need at the same rate that white patients do, et cetera. And so we know that there still continues to be discriminatory practices in health. And I think those need to be addressed. But more broadly, again, I think going back to, what really influences health and health disparities. We know that genetics plays a role in people's health, but if you take genetics out of it, 80% of what influences health are the non-health care aspects of things, health behaviors, and then those social and environmental factors that influence people's health. So that's why, we've taken the approach that, and we're not a health foundation to begin with, but we looked at the things that could make a difference in health and recognized that if we looked at those root causes, if we looked at economic inequity, if we looked at the things that pose barriers to people because of race and ethnicity, that those would also have a huge impact. And I think, the clear disproportionate impact in COVID-19, as well as the murder of George Floyd and the aftermath, I think has given us a moment of perhaps clarity and reckoning for the first time that racism really does have a tangible impact on people's health. I mean, it had a tangible impact in resulting in the death of George Floyd and many others, but we also know that the stress of racism itself poses a health threat. There's this concept of weathering, that, the fact that you are constantly under stress and your whole body is in that stress mode all the time has an impact physiologically, biologically on people. And so, I think it again speaks to why the mental health aspect of this is so important, because helping people deal with what is in many ways post-traumatic stress disorder from living with racism every day is something that we need to take into consideration while we address some of these broader determinants of health that we can also have a huge impact on. And, lastly, while we're talking about this and thinking about how this impacts African American and other people of color, we know that as a society, we are missing out because we are holding back large swaths of our population. What would we be like if everybody had the chance to exercise their full potential? And so this is hurting America as well as it's hurting people of color.
Thank you. In looking at your biographies, I've noted that you're both physicians with experience in the nonprofit and profit world as well. How do you help private sector leaders understand the need to address inequality in terms of healthcare?
Well, I would say, it's, and I think we should do this on many levels, we have to meet people where they are. And so one of the most important things that I think we can do is make the business case. As I, again, talked about speaking to business leaders here in Atlanta or in communities across the country, you make the economic case. Everyone, I think, business appreciates the fact that the local chambers of commerce appreciate the fact that if you want to attract businesses to better your economy, they are attracted to a healthy, educated, workforce. They are attracted to an area that has good transportation so that their workers can get to work. And so I think you meet people where they are and you make the business case. And I think we can make that very easily. If you look at employers, they actually want to keep their healthcare costs down, right? And so you do that by paying attention to all of these things that Dr. Gayle and I have been speaking about. I also want to bring up another sometimes elephant in the room. As psychiatrists, we like to make sure there are no elephants in the room because you can't solve a problem until you name it and identify it and get it out there on the table. And Dr. Gayle mentioned behaviors, and she's right, healthy or behaviors do impact a person's overall health. But and sometimes when people don't or fail to get beneath that headline, they begin to blame and shame people for their health and say that they are not making healthy behaviors. But one of the things I always like to point out is the choices you make are based on the choices that you have. And so if you have to drive, and in this I'm even thinking of a rule here, or maybe folks who don't have broadband access. So if you have to drive 30 miles to be able to get access to fresh fruits and vegetables, if you have to drive 30 miles to get access to a physician or hospital care, then is that really an equitable choice, especially if you don't have a car, right? I live in Atlanta, I have a car, I can drive, I can go to one of our higher end folks and get the healthy fruits and vegetables, higher end grocery stores and get the healthy fruits and vegetables that I need. So I think as we talk about behaviors, we need to put that in its full context. I know Dr. Gayle and I know that, but we need to make sure everyone appreciates that, and we can have further conversation about that. But I think it's about meeting people where they are and giving people really concrete ideas and practices as to how they can impact. So I like to give the business community, I like the transportation department, elected officials. Here's the policy that you can pass to get us where we need. Organizations with resources, the philanthropic community. You know, everyone has a role to play here. And we just really need to make sure that we are working collaboratively, and we need to get out of our silos and have a goal. If the goal, our goal here in Atlanta is to reduce the burden of chronic disease in 20 years, and sometimes you have to have these long-term goals, but you have to have some concrete steps, and we need to start taking action today. Actually, today is already too late. We're far behind on a lot of these issues.
Thank you.
Yeah, and I'll just add to that, clearly it is going to take all of us to be able to make the changes that need to happen. The government can't do it alone. The private sector can't do it alone. The nonprofit sector can't do it alone. So, it is really about building these kinds of partnerships where we each leverage our own, comparative advantages so that we can really bring something together that is greater than what any of us would do by themselves. But I would also say, talking about this issue of individual behavior and how we think about this in the context of companies and others, I think one of the things that is so missing in this discussion is that people don't have an understanding of systemic racism and what the systems and policies that were put in place that created a lot of what we're seeing today in terms of the inequities. And unless you have that better understanding of history and why we are where we are, it is easy to put the blame on the individual. You don't have enough gumption. You can't pull yourself up by your bootstraps. You can't do what somebody else did. And we're putting an unrealistic expectation on individual behavior when this is a systems problem. And so I think, whether it's health, whether it's economic equity, but I think when we talk about these issues of how we build equity, we've got to have a better understanding of what got us here today if we want to have the right solutions in the long run.
Thank you for that. I want to go back to this issue of history and actually take a question from Veronica, who's one of our audience members. Thinking about Tuskegee, and Veronica's been hearing from friends, lawyers, teachers, even other doctors that they won't accept a vaccine because they feel the research has been rushed and that pharma industry is not building enough time to truly track efficacy. The memory of Tuskegee is strong. Thoughts about how this will impact the pandemic and communities of color? If you want to respond to that?
Yeah, and I think, both of us have in different ways talked about how important it is to build trust with communities. And, I think we're all concerned that in this rush to find a vaccine, we might take some shortcuts. And as desperately as we need a vaccine, we definitely want to make sure that all is done that assures safety. And we have historical experiences of when that wasn't done and, the consequences accordingly, including the consequences of having people mistrust vaccines as a category altogether. So we've got to be careful about it. But I think really building the kind of trust within communities, sharing information, having doctors of color be part of the trials that get done, having decision panels that make decisions around vaccines and the use of vaccine and the trials, including people of color. So I think we've got to make sure that people of color are part of the solution and that we're building that kind of trust within communities, because otherwise it will backfire. When I was at the Centers for Disease Control, I headed this center that had the Tuskegee Benefit Program in it. It was the program that gave benefits to survivors of Tuskegee. And during the time I was there, President Clinton did an apology to the offspring, the next generation of people whose parents had been affected, and there were still some of the survivors still alive at that time. And what that meant to a community, to have somebody acknowledge their pain and actually apologize for a wrong that had been done, and what that did for building trust was huge. And so, I just go back to that to say, I think we've got to think about how we repair the damage that has been done. How do we think about how we build trust? And how do we make sure that people of color, and specifically African Americans, are included as these trials go forward? Otherwise, we will get to the end of it and have a lot of mistrust and not the result that we want.
Dr. Gayle, thank you very much. Dr. Harris, thank you very much. We are unfortunately out of time. I wish we could continue this conversation. It's really been an honor for me to be with you here today, and I appreciate you joining us here. So at this point, I want to transition over to introduce our next speaker, Dr. Whitfield, who I've had the pleasure of knowing for 25 years now. I would invite Dr. Whitfield back onto the stage and engage in a conversation that follows on the great thought leadership work of Dr. Gayle and Dr. Harris. So Dr. Whitfield and I, I'm thinking about when we first started working at the Baltimore Experience Corps study, trying to recruit a cadre of volunteers who were National Service volunteers. And that's when I first met you. But since then, you've moved on to Wayne State. And I wanted to let you introduce yourself to the group and also talk about how Wayne State, tell me about the Wayne State community and the city of Detroit. How are you all doing in terms of confronting coronavirus and helping your neighbors and colleagues?
Okay, so you gave me a complex question here. What was the first question?
Sorry, I just was recalling that we first met each other 25 years ago, but also, in terms of introducing yourself and then talking about Wayne State and the city of Detroit. What are you all doing in terms of confronting the coronavirus pandemic and helping your neighbors and colleagues?
Okay, so it's good to see you yet again. I think as you saw from my picture, you put some gray hairs on my head and on my face, but I'm working on that. I do serve as the Provost and Senior Vice President for Academic Affairs at Wayne State University, doing it for about 4 years now. I'm also a professor of psychology and been a gerontologist for 30 years or more now. We, as a city, it's been fascinating. because we are a city that is about 80 to 85% Black. And my president of the university is a physician. And I think it was quite apparent to him, it was quite apparent to lots of folks that as we saw some of the cases come out, you saw an incredible disparity. And it's interesting is that at one level you say, yes, wow, the disparity is incredible. And then again, we said, okay, that makes sense that we know about health disparities. He and I both are actually health disparities researchers. And so we started really thinking, I think as a city, as individuals with task forces, President serves on task force with the governor. I work with several community organizations and thinking about how this is playing out both in the city at large, but also particularly in our African-American communities. And so we have been, as a university, actually making some, I think we've been some of the first ones on the front lines of trying to set up mobile testing sites. We even have a hotline where people who are having mental health issues that are frontline responders. I think that's one of the things that you see in any of these places that are considered hotspots, is that the overwhelming challenge that comes from trying to treat people who may be on a course for mortality in a very, very short period of time is taxing not only physically, but mentally as well. And so my School of Social Work and the School of Nursing actually set up a hotline to make sure that they support it. As a university, we've actually supported frontline workers to actually come and use our facilities to stay overnight so that they could not have to go back to their families and possibly put them at risk, but they would stay in some of our facilities. So we've been doing lots of things like that to try to support the efforts to combat, but as many other cities, we have been kind of on lockdown and slowly but surely trying to slowly ease those restrictions so that we keep any resurgence from possibly happening.
Dr. Whitfield, one of the things that we heard from Dr. Gayle and Dr. Harris is how important the determinants of health, the non-medical determinants of health are. And your university announced last year that tuition, I'm reading this carefully, would be free for any high school graduate with a Detroit address who receives admission. And this is an initiative of significance. Detroit has a high school graduation rate of 88%, which falls to 28% for those graduating with a 4-year degree. How do you see this offer to residents of Detroit as making an impact on the inequities you see in Detroit?
Well, you're talking about one of my favorite programs, and we call it the Heart of Detroit. And this came from my team really taking a look and seeing who was coming to our university. We get about 95% of our students from a 100-mile radius, even though we have large international communities. Even Detroit, just to give you a little background, it's always fascinating to me that we're the most diverse university in the state. And in part, it comes from the diversity that's actually in Detroit. You might think about it just simply as Black and white, but actually we have the largest Middle Eastern population outside of the Middle East. So we have incredible diversity, actually, and there's a significant Hispanic community that's there as well. And so we have all of this there that makes our university actually a fantastic university. But we really thought about access and affordability issues. It's something that we keep a mindful of because we know that education can be a driver for both economic prosperity and even in terms of supporting healthcare. So we figured out a way to be able to offer, if you had a Detroit address, that we would offer you free tuition and fees. And we did this because it's about our values, it's about who we are, and it's our commitment. And it was done in part because I have a woman by the name of Dawn Medley, who's my Associate Vice President for Enrollment Services, who really did the research to figure out, could we afford to do it? And through the philanthropy that we just completed on a capital campaign, that a lot of it went to helping students and student success, we figured out a way to pull it off. And it's just one of those things that when you're an urban research university, when you're a community engaged institution, these are the kinds of decisions and thinking that you do constantly. And I think that we just made that bold move, and we're trying every way to be able to make sure we provide the opportunity for success for people of Detroit. But let me, I caught a little bit of flack for this when we first announced it, that people said, well, what if I'm outside of the city of Detroit? Well, don't I get free tuition and fees? If we have our way, someday we'll get there. That's what we want to do. We want to make education affordable because of all of the things Dr. Gayle and Dr. Harris talked about, which, you know, I'm an educator. They're speaking my language when they talk about the educational piece of it and how it can be a very important driver in terms of making a healthy society.
So Dr. Whitfield, we have a question from the audience. So you have worked with individuals and organizations from across the spectrum, global NGOs and some of the nation's biggest corporations. How do we build a path forward when we are sharing ideas across different sectors and not competing, not competing for the same resources?
Yeah. You know, that's a great question. One of the interesting parts about the new normal that I think about that will come on, we're experiencing now through the pandemic, and we're going to experience it on the other side, is how we actually use this very medium to be able to connect in different sorts of ways, I think, than we did before, because it's real time. It's not just watching a video on YouTube. It's actually really trying to connect with people in a different sort of way, and I think we're getting better at it. I think we need to use these capabilities to break down barriers of place and time, to share knowledge, share strategy, and problem solving. That's one of the things that the outrage over the death of George Floyd has brought, is that we're seeing this not as a United States problem, we're seeing it as an international and a world problem. And that gives me actually more confidence that we will hopefully in our societies be able to struggle and to strive towards creating more equitable societies, not only in this country, but around the world. That's what I see happening, and it's being driven by the Black Lives Matter movement. But it's going to be something that we have to turn ultimately into not only the idea of civil unrest about things that are not right or should be a different sort of way, but also changing policy. And that means that we have to vote. That means that we have to be citizens. And that means that we have to create communities. And I think we can use technology to be able to help us do that, to connect in very, very meaningful ways. But ultimately, it's going to be, and as soon as the pandemic is wherever it's going to be, we're going to be connecting person to person. But we need to create those different types of societies and interconnectedness.
You know, Dr. Whitfield, when we first met, I knew you as someone who was a leader in longitudinal studies of twins. And I want to build off of that experience, looking at a life course and also your own career. This idea of zip code being, you know, your destiny is a relatively new one. What are some things across your academic career that you've noticed have emerged? And if you could peer forward, you've mentioned one, this idea of interconnectivity. What, if anything, could be key drivers in looking across your career of these disparities in longevity?
So I thought it was interesting. I do want to go back and cite Dr. Gayle, who I think she was giving me the perfect lead-in for what we learned from twin studies. I have one of the very rare twin studies of African-American twins, of adult African-American twins. And she's very right that what you see is that there's a lot of environmental variability that creates both similarities between twins and also differences in twins. And so some of the things that she mentioned in terms of environmental factors, I think are important. Some of it is both current and historical. You know, so I'm a gerontologist, and so I not only think about what we deal with and what we're thinking about at the moment, but actually the life course of people. And when you think about it in that manner, you have to always do your reverse mathematics. So people who are 60 now, let's see, they were born in, let me do the math right, 1970. No, 60 or 50. No, where am I doing? 1960. So as we think about that, we have to contextualize when they were born and the things that they went through. Did they, when they were in the years in which they might have been doing, going to work and starting to work, or maybe even starting school, what kinds of things actually were there? So one example is thinking about educational desegregation. You know, it happened in 1954. And if you think about those folks, they're now retired, but they went through a time when opportunities were probably being taken away yet again as a point in time in history, as we were trying to desegregate. That a lot of people think that desegregation ultimately leveled the playing field, but it didn't seem to level the playing field for many. We're still seeing the disparities both in education, in terms of work, and in terms of health. And so it wasn't as effective as we want to think that it was, but it did have implications for variability in individual characteristics for those folks. So hope I answered your question there. You got me started on some stuff that I've been looking at and thinking about for years. And it's always very complicated. And one of the things that I want to say that I don't think we brought out here is the idea of successful aging as well. Of that sometimes we only think of the problems that racism creates, and it does create a myriad of different problems and challenges for people to be able to make it to later life. But one of the things that I've been focusing on my most recent research is that, yes, if we have these huge disparities, who's living to very late lives? And actually, it means that African Americans are less likely to live at very late lives. So if we really want to know the success for everyone in society, we'll actually take a look at the very old African Americans, because maybe there's some secret sauce, there's a key to that, what they're bringing and what they've experienced and how they're processing, how they're dealing with stress, how they're coping with stress, and maybe even some of their genetics that might give us insights to how we can live successful, long lives.
So you mentioned, Dr. Harris mentioned stress, and you've worked on issues of stress and mental health. Could you talk about that in terms of how that has become an issue and what we can do to help address that?
Yeah, that's fascinating. And I'm keeping an eye on the clock and just knowing how I can tend to want to lecture on things. But my current study actually is looking at stress within African-American families. So when you think about stress, stress is a perception. Stress is a perception of the environment and how we're interacting with it, what it is or isn't doing for us and doing to us. And we have to think about it in a way of that we learn stress to a great degree. There are physical ways that you can stress somebody, but for a lot of stress, we learn it. And my question has always been, so where did we learn it from? And we learn it in part from the environments that we live in and the families that we live in. And so this deals with the legacy of the inequalities that have existed in our society for years and years and years, and that those translate into things that are passed down through families in terms of perceptions of what life's like. I was recently talking to a news outlet and talking about what I thought about what we might come out of the George Floyd incident with, and I'm torn, because 20 years ago I can remember telling my stepson about how he's supposed to deal with the police. And it made me think about it. I thought, wow, and maybe 30 years before then, I remember my father talking to me about how to deal with the police. And I know for my stepson, he's now talking to his kids about how you deal with the police. And so those perceptions of stress and how we navigate environments is something that it's intergenerational. And it comes from the environment changing in some ways, but still needing to have a certain sort of perception of risk and safety and how you navigate it. I think for African Americans sometimes that may be that you almost have to have two minds. You have to see what's going on and you have to think about all the things going on behind it. And that poses an incredible challenge. But in this study, we're trying to see whether there are patterns of that. Maybe if people didn't cope well, if families didn't have good coping strategies, that what we're seeing is that those are the families that experience early mortality, and that the ones who maybe had some other kind of coping or perspective or thought about the world, maybe those are the ones that we see in patterns of longer lived families. So we're looking at siblings in long-lived families and short-lived families. Short-lived families are ones where if you're in your 50s and your 60s and your parents have passed away from a chronic condition mostly. And then the long-lived families are looking at siblings where their parent is still alive, and to see if we can find some interesting patterns. So like I said, don't get me started on that. That is going to provide us, I hope, with some very interesting insights about how stress ultimately impacts our lives, our health, and longevity in African Americans.
So I'm going to finish this because we have limited time with sort of a two-part question from two of our audience members. What would be 1 to 2 major state policy reforms that could address the systemic racism in our health and long-term care system? And what are some game changers that could drastically shrink the equity gap in the next 10 years? So state policy changes and game changers over the next 10 years.
Wow. So hard question. Some things that I think need to happen. A lot deal with our healthcare system and the things that we do to actually preserve our health. For example, that I'd love it, particularly for older adults. I'm sorry, I'm a gerontologist. I just think this way of that having regular wellness check for anybody over 65, doing mindfulness training for seniors. Mindfulness is making sure that you can actually find a way to be able to cope with the daily stressors that actually come and to find a very productive way to be able to do it. There's lots of evidence that shows that it can reduce blood pressure, which in African Americans, quite disproportionate, particularly African American men. So that would be a wonderful solution. Be able to support family members by providing emotional support for their parents and elders, and even really providing support for the family members. We have lots of policies that if you have a child, you can take time off, and even for for both members of the parents are now able to do that. There needs to be some policies that actually support when family members have to take care of their parents. Address limits of transportation, housing, and healthcare. Those are things that are going to start evening the playing field in terms of being able to have access. And additional training and improved pay for nursing home staff members. This is something that I think is quite overlooked and not thought about the people that are taking care of those folks. They also can be quite instrumental in creating contexts where African American families can feel comfortable about leaving their parents or someone that they're caring for with someone else. That's very, very difficult. And there's a cost issue as well there. But if you could overcome those things, the care as we grow older and if we need more attention and care, I think would make the playing field a lot more level than what it is, because it's not that way now.
Dr. Whitfield, any last thoughts that you wanted to provide us before I turn it over to closing remarks?
Sure, and I'll attempt to be short, is the idea that one of the things that I love about aging, like I said, I've been a gerontologist for 30 years, and that is that aging is for everybody. But aging is also something that while we all experience it differently. And it's one of the things that actually clearly shows the racial inequities that we have in this country. And it offers us an opportunity. But it's also one thing that as we take a look and think about aging, sometimes we don't pay attention to it until it's too late, let's say, until you actually are older. We age every single day, and every one of us does it. So there are things in terms of our development, in terms of taking care of our health throughout the lifespan, and not just in the later years, that we need to concentrate on. It's another form of inequities that needs to go along with some of the social reform that we've been talking about and thinking about with the George Floyd piece. So I'll stop there, and I really appreciate the time today and the opportunity to share. I thought Dr. Harris and Dr. Gayle raised some incredibly important points that I hope that we can all gain from and think about and find ways to change our society all for the better.
Dr. Whitfield, thank you very much. I also want to thank Dr. Harris and Dr. Gayle for joining us earlier, and for the leadership of Dr. Debra Whitman in helping engage us with helping to lead this engagement with the Social Innovation Summit. I think that what we've heard today is that while we're seeing all these disparities created by the COVID-19 in terms of serious illness and death, that these are building on the determinants of health. Specifically, to name it, racism is one of them. And that as we consider a recovery, that we cannot go to where we were. We cannot go to the past, that we need a reset, and we need to think about a more equitable future. And in addressing the disparities for Black and Latino people, that we can make all of our lives longer. So thank you very much. And I'm going to turn it back over to Mel.
Wow. Thank you, Dr. Tan, for moderating these two powerful discussions. And thank you, Dr. Whitman, for your opening remarks. Again, on behalf of both AARP and Social Innovation Summit, I'd like to thank all of our incredible speakers, Dr. Gayle, Dr. Harris, and Dr. Whitfield, amazing experts. This conversation is part of a series of conversations that AARP is leading in partnership with SIS on longevity and equity. We will be in touch with additional information on future convenings, and we hope you can join us as we explore how to build equity into the post-COVID recovery so that communities of color have the opportunity to live longer and healthier lives. Thank you for sharing your time with us, and have a great day.